Well, welcome everybody. Thanks so much for joining us. My name's Karen Canfield from the Daffodil Centre, University of Sydney and Cancer Council, and I'm on Ku-ring-gai land here in Sydney. And I'd like to welcome you to the second Whole of Consortium call for June. This is our 6-monthly call. Our last call was in December, and there's a huge amount to update members on in terms of the activities of the CCGMC. So we do have a really packed agenda today with lots of presenters. As I just mentioned, we had in the first call we had over 70 participants, and this looks like it'll be a slightly smaller group, but all to the good. And overall, over 100 people still actively joining our calls and participating in the work of the consortium, which is absolutely fantastic. So I'm really delighted to introduce my co-chair today, Dr. Rami Rahal from the Canadian Partnership Against Cancer. And Rami, thank you so much for your efforts on behalf of the CCGMC as one of the steering group members. And I'll hand over to you to welcome and kick us off today. Thanks.
Excellent. Thank you very much, Karen. So as Karen said, I'm Rami Rahal with the Canadian Partnership Against Cancer. I'm speaking to you today from Southern Ontario, Canada, which is the unceded territory of the Anishinaabe, Wendat, and Haudenosaunee First Peoples, as well as many Indigenous peoples that call Southern Ontario their home. So we're excited today to bring you some really great work and updates on areas of progress that we've been focused on in the Cancer and COVID Global Modeling Consortium, lovingly referred to as the CCGMC. And this is on behalf of our key partners, UICC, WHO, CPAC, International Cancer Screening Network, and the Daffodil Centre, as well as acknowledging our affiliates at the HPV Prevention and Control Board and the Association of European Cancer Leagues. So this is, we I think often refer to some of the silver linings that came out of the pandemic to promote and encourage international collaboration on key areas of mutual interest. And this collaboration has been one of the, the shining examples of how, we can accomplish a lot more together, bringing our resources, our intellectual capacities, and our creativity across countries with common challenges dealing with COVID towards developing modeling platforms to really sort of estimate and forecast and understand the impact of COVID on cancer, with the intent of informing decisions at the policy levels. And really governments are primarily our target audience here. And so we've been working on a number of key areas, 3 working groups, which you'll hear more about. One focused on treatment, one focused on screening, and the third focused on prevention. And we have produced some important results and recommendations and findings coming out of this work that you'll hear more about today. So we are going to, again, as I said, review some highlights, provide some updates on a number of commissioned projects from CRUK, ICDP, and WHO, and give you a bit of a taste of some of the working group activities, those 3 working groups that we talk about. And finally, get your input on some branding, which is an exciting part of this meeting. So yeah, if you can just use the chat function to add any questions and comments, and we'll look at them at the end of each session. If we have time, we'll respond. If not, we'll try and get back to you at a later meeting. Next slide, please. So we are going to start with an update on COVID-19 and the Cancer Task Force, and then we'll get into some of the other components. So without further ado, I think Richard is with us, hopefully. So Professor Richard Sullivan, I will turn this over to you. Is Richard with us?
Maybe Richard isn't with us. Harriet, we'll just ask you to double check. Rami, I can do my best to quickly run through Richard's slides if you like.
We can do that, or we can go to the next agenda item.
Actually, I think that's a great idea. He may well come on stream later on.
Okay.
Okay.
Yes. Dr. Sullivan has been on occasion known to be a bit late coming to these things. All right. consortium highlights and upcoming events. So we'll move on to the next slide, please. Excellent, thank you. So just sharing with you some exciting work that we have published within the consortium over the last year. So to date, the consortium has published 3 systematic reviews, one on changes in smoking behaviors during the first phase of the pandemic. Another looks at whether cancer patients have a higher risk of dying from COVID-19 compared to non-cancer patients. And then one on looking at the risk of contracting COVID for people with cancer. So 2 of these systematic reviews have led to new work with the WHO, and you'll hear a bit more about that later with Andre. The steering committee has also published an editorial discussing the role of the consortium itself in informing mitigation strategies and supporting pandemic recovery approaches. And you can access all of these papers through the consortium website, which is on this slide, ccgmc.org. We're also excited to share that we have a major session at the World Cancer Congress in Geneva coming up on cancer services disruptions as a result of COVID. And we'll be hearing from Karen, Isabel, Freddie, and Iris on some of the global challenges faced across screening, treatment, and care, and how they affect cancer outcomes. We also have 4 abstracts that were accepted, one by the Australia-Canada OSCAN modeling group, the Colorectal Cancer Project team, and the COVID and Cancer Systematic Reviews team. So we're excited about that. And we also have a couple of systematic reviews that were accepted as well. One looking at the risk of COVID-related death for people with cancer, and one looking at the disruptions in cancer screening, diagnosis, and treatment during the COVID pandemic. And we also are excited to launch our global observatory as part of a workshop during the Congress. And you'll hear Isabel today will give us a bit of a demo, sneak preview of an early version of the observatory, showing you some of the key features there. So again, I'd like to congratulate all of the members of the team who are involved in putting together all these sessions and abstracts. And I guess over to you, Karen and Isabel.
Oh, well, thank you so much, Rami. So Isabel and I'll now be taking you through the commission projects, but we'll actually be introduced by the various representatives of the funders. So I'd particularly like to acknowledge and introduce Harriet Hall, representing the International Cancer Benchmarking Partnership, who's going to tell us about the rationale for commissioning research. Over to you, Harriet.
Thank you, Karen. Good evening, everyone. As Karen said, my name is Harriet Hall, and I'm the Senior Programme Manager of the International Cancer Benchmarking Partnership, or ICBP for short. I just wanted to provide a brief overview of what ICBP is and why we decided to commission this project before Karen provides a bit of a progress update. Next slide, please, Harriet. The ICBP is a unique and innovative collaboration that brings together clinicians, policymakers, researchers and data experts from across the world. It measures international variation in cancer survival, incidence, mortality, stage at diagnosis and survival by stage, as well as identifying the factors that might be driving those differences. We produce high quality research to help identify best international practice and generate insights needed for policy and practice improvement. We do this to enable the optimization of cancer services and ultimately to improve outcomes for cancer patients. All of our jurisdictions have population-based cancer registries, a similar spending on healthcare, and universal access to healthcare. So the partnership is made up of high-income countries, although we do share our findings more widely. In March 2021, we entered into a 2-year transition phase to enable us to reflect on the past 13 years and to give us some time to plan for the next phase of the ICBP. As part of the transition phase, the partnership wanted to commission some research with the primary objective of understanding the impact of COVID-19 on cancer outcomes and cancer services for our jurisdictions. We therefore commissioned 2 complementary research projects, one with a quantitative focus led by Isabel from IARC and the other a qualitative focus led by Karen. If anyone is interested in learning more about the ICBP partnership, I will pop my details in the chat, but for now I'll pass over to Karen, who can provide a bit of an update and overview of the project. Thank you.
Thank you very much, Harriet. And we're really excited to be working with the ICBP because of all of the major synergies with our objectives and the work programs. So as Harriet just said, we have two parallel projects. One is a qualitative project led by the Daffodil Centre, and the other is a quantitative registry data analysis based project led by Isabel and IARC. Next slide, please. So the context, of course, for this is very different experiences through the pandemic in terms of NPI severity and NPI dynamics through 2020 and 2021. And this is just illustrative of some of the key ICBP jurisdictions, obviously all high income countries, but you can see the enormous variations in stringency and differences in the dynamics over time. And so the key aspect here is really to characterize and map these disruptions as they then impacted cancer services. Next slide, please. And this slide just illustrates in a little bit more detail how the projects will run along together and fit together. So the quantitative project will quantify the impact on cancer outcomes, looking particularly at, for example, at drops in cancer diagnoses through the pandemic, initial drops at least, and then potentially, unfortunately, increases. It will involve statistical analysis focusing on breast, colorectal, lung, and ovarian cancers. And this will sit alongside this mixed methods approach, which will involve a high-level desktop review of the grey literature, as well as stakeholder interviews, focusing on most of the same cancers. And then these two lines of inquiry will be brought together to assist in interpretation of the data, as well as the quantitative analysis, potentially pointing to areas where stakeholder input could be valuable. Next slide, please. So I'll hand over to Isabel to talk to the methodology now for the quantitative analysis.
So as for the quantitative assessment of the impact of COVID on cancer diagnosis, staging, but also outcomes, looking at the mortality and survival, we have requested now cancer registries from the 21 jurisdictions, the 7 countries within ICBP partnership, for a request and call of data of new cancer cases that are then registered within their area, the coverage area, before the pandemic, but also then during the COVID pandemic. We are also requesting for cancer-specific death information, and then also background mortality and population data. The idea is really then to perform prediction using then background trends. That's why we're asking quite a long period of time of data requests to enable us to do that, and then map what the difference between then what we observed during the COVID pandemic with what the predicted incidence and cancer deaths would look like without the COVID pandemic. With that, we'll be looking into then differences by sex, by age group, cancer types and site, and we're really also then trying then to look into then changes in stage distribution. And of course, this will all be linked to the non-pharmacological interventions, so the COVID control, and the qualitative study that Karen will present after this.
Thanks, Isabel. And just very briefly, the mixed methods approach involves a comprehensive desktop review, as I mentioned, mapping of the timeline, surveys and questionnaires within stakeholders in jurisdictions, as well as interviews of key stakeholders, sitting alongside some specific case studies where we do a bit more in-depth analysis of specific areas of health services, using a compare and contrast model to really understand how the crisis has played out in certain parts of health services in different jurisdictions. Next slide, please. And this just illustrates the types of documents we'll be looking at for the desktop review, policy documents at a national or jurisdictional level, hospital and service provider documentation, practice changes and guidelines, and recommendations from peak bodies and organisations. Next slide, please. And some of the case studies that we'll be looking at include, for example, compare and contrasting experiences for breast cancer screening services across 4 different jurisdictions, which actually had quite different experiences. in 3 jurisdictions in Australia and 1 in New Zealand. A second case study that's comparing and contrasting changes to pathways to diagnosis for symptomatic lung cancer in Ireland and the UK, with the potential for a compare and contrast with a Canadian jurisdiction. And also thirdly, understanding changes to delivery of treatment services with a focus on surgery for colorectal cancer in Wales, again with a potential to include another jurisdiction for comparison. Next slide, please. So I'd now like to, that's the ICB project, and we thank Harriet and ICBP gratefully for involving us in this important work. So we'd now like to move on to tell you about another commission project, and to introduce it, I'd like to hand over to Alexander Wright from Cancer Research UK. Alex, over to you.
Thank you very much, Karen. Hi, I'm Alex Wright. I'm the global lead at CR UK, and I lead a small team within CR UK focused on supporting progress on selected global cancer issues through our International Cancer Prevention Programme. This is a policy-focused programme, so we support policy-relevant research, capacity building, and advocacy designed at supporting evidence-based policy change in low and middle-income countries. And we have 2 areas of thematic focus. One is tobacco economics, and the other is the elimination of cervical cancer, particularly through the expansion of access to HPV vaccinations. And in this context, we were really excited to come across the observatory and to support the development of the observatory. We are really excited by the potential of placing an interactive tool in the hands of policymakers and of advocates to model and really understand the different vaccination scenarios, how to deal with the disruption from COVID. And alongside that, the potential to develop policy briefs and best practice advice. Together, we think this is the potential to make real impact. We're also really ambitious for where this could go, beyond just modelling for COVID disruption, beyond just cervical cancer. So we're really excited to play our part in supporting this initiative. And we'll do so initially by also working with Karen and the team and IARC and others to make sure we have a successful launch and dissemination at WCC and beyond. So at this stage, I'll hand back to Karen to walk you through the observatory itself.
Thank you so much, Alex, and thank you for your support of the CCGMC and our observatory development. So as Alex said, the first iteration of the observatory will be focused on vaccination disruptions in LMIC. And this will build on the original cervical cancer elimination modelling that was done by a consortium to support WHO's original elimination planning and the plan that was launched in 2020, which defined 90, 70, 90 targets by the year 2030. So that's 90% vaccination coverage, 70% screening coverage with HPV screening, and 90% access to treatment for women that require it. So the first iteration of the observatory is actually focused on loading up these original elimination predictions. And then we're currently doing a lot of detailed country level analysis of vaccination disruptions and delays and modelling out some mitigation strategies, which will be the focus of the observatory. So next slide, please. The idea with this is that it will be not only an interactive observatory, but the observatory will have an interface with the generation of country level policy briefs, which can provide countries with tailored information as to lives that can be saved by elimination and best practice recovery strategies. And this will build on some earlier work that was done by the Daffodil Centre team. You can see here an example of what this type of policy brief can look like with tailored numbers for a country. Next slide, please. And of course, as we've said, this will be the first iteration of our long visualized COVID and Cancer Global Observatory. And just a reminder that the long-term vision here, as Alex has said, is about much more than cervical cancer. It's across all cancers. And it's also about much more than modelling. It's essentially The vision is to have a central reference point for the latest evidence on COVID and cancer, whether that's coming from our systematic reviews or our modelling and interactive tools, and that this is kept up to date and living with up to date and current information for policymakers. So I'm now going to hand over to Isabel, who'll take you through a little bit of a demo of the first iteration of the observatory.
So I'm really proud then to show this observatory, the platform for which then we have now included cervical cancer data, the scenarios based on then the 3 targets, but also then complete targets. And then we have also then added in here scenarios in terms of disruptions in services of these 3 areas in cervical cancer control and how it may impact the future elimination targets. So if you look then into, this is then how the outlook of the platform looks like. The user then can choose in terms of then the data that is outputted, either then incidence and mortality. They can select for age group that they are interested in, as well as the population that that is then available here. At the moment, we have data for 78 countries, and what I'm showing here is then for all low and middle income countries combined. So on the gray line, you'll see then how cervical cancer rate would look like in the future if then the rate remains stable. And then on the yellow line, you'll see then how then cervical cancer would look like if then the 3 targets that were mentioned before were then achieved. Next slide, please. And then you can then add different scenarios on top of then the default scenario, starting from different scenarios if you would like to. For example, in the new line that is then presented here, you'll see then the scenarios where then in terms of the targets, only the vaccination that were then achieved. You can add another line to this. Next slide, please. For which then the vaccination is accompanied by screening and so on, as it then get deeper then into then the different scenarios and strategies. In addition then to all countries combined, you can of course then look into then how the cervical cancer future trends and then targets would look like by selecting the country. So I am showing here then in the next slide how the scenarios would look like for Uganda. It is one of the countries with the highest cervical cancer rates in the world. And then if you see in the next slide, please, we're changing then setting. So similarly as before, you see again then how then cervical cancer look like at the default options if then the targets were to be achieved. And then on top of that, by clicking on the delays, different scenarios, you can add how it would look like, for example, if there were then delays in all 3 of the services, meaning vaccination, screening, and treatment. Again, you can then select for incidence or mortality, depending then on the interest, or changing the countries or even then regions that you would like to deep dive into then the analysis or the assessment of the impact of the disruption. Back to you, Karen.
Thanks very much, Isabel, and we're so excited, of course, about this this major development. So we're now going to move on to tell you about the 3rd set of commission projects. This is now, next slide, please. We're going to now tell you about the WHO Commission COVID and Cancer Systematic Reviews. And as Rami said earlier, this comes directly from the first iteration of reviews that we did that have just been recently published. And we're now working on updated reviews for the WHO. I'd now like to hand over to Dr. Risha Shah from IARC, who will tell us about where we're at. Thanks, Risha.
Thank you, Karen. Can you hear me? Yeah. All right. So hello, everyone. Good evening, good morning. I'm Richa. I am a postdoctoral fellow at IARC, and I'll guide you through the 3 reviews that you are currently performing. So Based on our previous work and discussions with Andre and Felipe, we have prioritized 3 topics for systematic review. The first one is the risk of COVID-19 related death for people with cancer review, which aims to determine whether people with cancer are at higher risk of COVID-19 related death than people without cancer. The second review, magnitude of cancer care delays and disruptions during the COVID-19 pandemic, aims to determine the impact of the COVID-19 pandemic on delays and disruptions in cancer care. And the third review, impact of strategies for mitigating delays and disruptions in cancer care due to the COVID-19 pandemic, aims to determine the impact of strategies for mitigating delays and disruptions in cancer care due to COVID-19. These 3 reviews are being undertaken by a large group of reviewers from around the world. We would like to acknowledge the great international team of CCGMC members who are contributing to this reviews. And we have already made substantial contributions to the title and abstract screening, the full text screening, and the data extraction phases for each review. This tremendous work would not have been possible without them. Next slide, please. So collaboration with CCGMC members is an important part of this work, and novel processes were developed for smooth and efficient running of these projects. For example, to facilitate the title and abstract screening by such large numbers of reviewers, we developed a system for allocating abstracts to reviewers, monitoring progress, and identifying discrepancies. We also used training sets of abstracts to reduce discrepancies between reviewers. And we have regular meetings with reviewers to discuss highlights and also resolve challenges together. And the same process is also being continued for the full text screening and the data extraction phases of our reviews. Next slide, please. So we have discussed the PICOs and PECOs of these 3 reviews in our previous meetings, but I'll run through them very quickly. So for our first review, the population, which is the risk of COVID-19 related death for people with cancer, the population is COVID-19 patients or general population regardless of the COVID-19 status. The exposure could be pre-existing cancer diagnosis, the cancer status specified as diagnosis or treatment with cancer during a specified period, or current or active cancer as defined by the study. And the outcomes are death from any cause or COVID-19 related death. Next slide, please. So based on our rigorous search strategy, we identified more than 16,000 articles for this review. The title and abstract screening is complete for this review, and all articles were screened independently by at least 2 reviewers, and any discrepancy was resolved by a 3rd reviewer. To date, we had 918 articles which have been screened by at least 1 reviewer for full text, and about 40% of them have been screened by at least 2 reviewers. To date, we have 6 articles that are eligible for inclusion. The number of included studies to this date is a reflection of the stringent inclusion criteria, which are designed to include only high quality evidence. And the data extraction and risk of bias assessment of included articles is occurring concurrently and is ongoing. Next slide, please. So our second review, which is on the magnitude of cancer care delays and disruptions during the COVID-19 pandemic, we have identified 2 population groups, which could be cancer care services or individuals. The exposure is the COVID-19 pandemic, and the comparator is any period before the pandemic. And the outcomes have also been divided into service level outcomes and individual level outcomes, mostly pertaining to the number of diagnoses, treatment, number of people screened, and the duration from diagnosis to treatment. Next slide, please. Our final review, which is the impact of strategies for mitigating delays and disruptions in cancer care due to the COVID-19 pandemic. Again, the population is the same as our second review, and the outcomes are also similar. But for this one, the interventions are any kind of mitigation strategy that had been taken during the pandemic to decrease the delays and disruptions occurring because of the pandemic. And the comparison was based on the time period before the pandemic or during the pandemic, or any comparable setting where the mitigation was not employed. Next slide, please. So for the last two studies, we used a common search strategy, which identified more than 9,000 articles. And from this 9,000 articles, we included about 1,000 articles for full text screening. And the data extraction and risk of bias assessment for these two reviews are ongoing. For our next steps and timelines, we hope to complete this reviews shortly. And we plan to submit a draft manuscript before the end of July. We hope to share the final results with you in the next CCGMC meeting. That's all from my side. Thank you.
Thank you so much, Richa, and congratulations to you and all, all the many consortium members who've done so much to make this a reality. It's just an extraordinary effort and enterprise getting so many articles screened, and thank you. It's really important work. So I'm now really pleased to introduce Dr. Philippe Reutberg, who is representing the team that we're working with at WHO on COVID and cancer, and not only on the systematic review work, but also the two modelling teams. The consortium is, of course, also developing a global platform, and you hear about some of the initial steps there. And the two modelling teams, I think, have greatly benefited from sharing data and insights and meeting regularly. So, Felipe, we're delighted to welcome you today. Over to you.
Thank you, Karen. So good night, good afternoon, and good morning for those who are attending to the session today. It's a pleasure meeting you now, and to just update about the partnership that you just encompassed so brilliantly. So just to put the context about this presentation, the idea is to set the context of why we are modeling COVID into the moment, measuring impact of COVID on cancer, to global response, how we generate evidence-driven response in line with the political commitments that we assumed, and 3, to WHO signature solutions in partnership with our dear partners, as for example, the consortium model here that we're discussing. So next slide, please. So just to introduce and set the stage why we are discussing at the moment, because we have the feeling that we are all safe because the vaccine reduced the number of deaths. And we are quite sure it's true because we see the mortality reduced so much, but the mortality related to COVID, direct mortality. And if you take a look at indirect mortality here, this is recent data that WHO recently launched. The assessed mortality, which means the mortality that exceeds the expected and also due to COVID, it's about 15 million deaths. And the reason for that is the unexpected consequences of COVID related to the indirect deaths related to disruptions in the healthcare system. Next slide, please. So considering the mandate that we mentioned, we are now trying to support countries through the global goods and through leadership, but it's not enough. And the reason why it's not enough, because we are not having the powerful message in terms of how can we make better trade-offs and where are the disruptions that our dear colleague Richard just mentioned. And the disruption systematic reviews aims to also address not only if there are disruptions, but where are these disruptions whenever they are provider related, healthcare system related, or patient context related. Next slide, please. In this regard, we did a systematic reviews about 1.5 years ago, and we found about 36 points for disruption related to diagnosis, treatment, screening, and palliative care. Next slide, please. So the point what we have now, we still have for key 4, which means that after 4 quartiles of monitoring from WHO, we still have severe disruptions. And it's not, as I mentioned, related to the excess mortality. It's not the direct death related to COVID itself, but the consequences for the healthcare system disruption. So we still have disruptions related to health promotion, disease prevention. Next slide, please. And related to cancer, if you compare the quartiles, we still see severe disruptions that started from 47% in the first quartile and now 41%, increasing the more than 50% of the services disruption also remains, and 35% also related to 5 to 50% of the services disrupted in countries. So we now try to map diagnose, treatment, and screen. Next slide, please. The most affected services in the question what we pose, if they are unintended or intentional service delivery modifications, as we see here, 50% are still intended service delivery modifications, which means that which reinforce the value of this partnership to provide a powerful message of where and how to map where are the disruptions and how to mitigate them, which is also relates to the 2 systematic reviews that Richard just mentioned a few minutes ago. Next slide, please. So what is new from what we know? Because we've been talking about disruptions and deaths. Now it's time to run the model and to use the data that has been provided by the consortium modeling. The assessed mortality here, methodology has been defined by WHO, which means that we are now aiming to follow the model and understand what's the shared mortality related to cancer. We have new data from systematic review that's up to be ready in a few weeks. So we have better inputs, and thank you again, Karen, and the whole team. The Python model is now mature. We have piloted for the Appendix 3 updates, and we validated the data related to how this affects disruptions, especially related to screening, to diagnosis, and now treatment. And we piloted in at least 2 countries, and there are 17 more on the list. And we have real-world data for modeling and member states that aims to use this, which means there's actionable data that this team is producing, and it means that we now aim to mitigate and provide mitigation strategies fit to what the healthcare system needs, which are those who are outcome related. And that's why it's so hard to find this data related to quality data that is related to outcomes. Next slide, please. So the idea is to make better decisions and trade-offs of exposing the patients related to type of cancer, type of treatment, comorbidity that exists, and the protection value of the vaccines for cancer patients. So we may have better decisions in terms of risk benefit and cost benefit, because this tool is built up on the model of choice, which means that we aim also to later on build back better and use the model to also project healthcare system improvement. Next slide, please. So just to finish, next step we envision using here marked in red the results of these 3 systematic reviews that are massive amount of work, as has been recently mentioned, and they aim to fit the publication to provide publication peer review and also fit the model in the sense of we now aim to use it for the framework and assist member states and those in need and those who aim to use the model as a Python platform that aims to be also a friendly user. Thank you again, Karen, for all your effort and all the team for supporting this initiative. And we are glad to also be part of this group. Over to you.
Thank you, Felipe. It's back to me, Rami, now. Really important work. Just to highlight the magnitude of the unintended consequences and the focus on the midterm impact is really critical. So appreciate your work and that of your colleagues. Now we're going to switch quickly to reports from the working groups. So we've got 2 minutes for each group, starting with the breast team, and Dr. Carolyn Nixon is going to take us through that. Carolyn, over to you.
Thank you. Next slide, please. We've spoken about our team before. We focus on collecting data from screening programs, some collaborative modelling, contributing to the global modelling effort, and a systematic review. So I'll just give a quick update. Next slide, please. The 3 strands of work we're focusing on at the moment are the global modelling, our collaborative modelling with Italy, and some systematic reviews. And we've previously shown these timelines and we're tracking along on those quite well. Next slide, please. In terms of our collaborative work with Italy, we've established a framework to do it in phases, so working to a higher level of modelling and then going into more detailed modelling. We have done quite a bit of detailed modelling here in Australia, looking at COVID impacts, not just in terms of overall participation, but in terms of which different risk groups were prioritised for screening during the recovery period, and what this might have meant for not just mortality, but the profile of tumours being diagnosed and the downstream consequences for treatment services. So we do have that sort of lovely level of detail that we can bring to this collaboration in a staged process. So we are making some traction there and moving into this sort of second phase, focusing on the relative change of outcomes of interest compared to business as usual. And then in the third phase, moving into some more detailed modelling. We've also within the group conducted a systematic review of breast cancer screening, and this focuses on volume-based data. So looking at throughput in different screening settings of people attending breast cancer screening. There were 20 papers that were eligible for this systematic review, and the primary analysis is comparing throughput for 2020 after that first COVID wave compared to a similar period, some sort of comparable period prior. And this graph here provides some summary information where the colour coding indicates the types of screening that are provided in these settings. So, for example, most of the data comes from population-based screening settings. However, we see some data from Mexico and Brazil where population screening is limited and supplemented by private and national health insurance. And then in the red there, the US setting. So we have submitted an abstract for the IARC virtual conference in November, and we're preparing a publication around this work. Thank you.
Thank you very much, Carolyn. Now moving to cervix, Dr. Megan Smith. Megan, it's all yours.
Thank you very much. So on dissemination, we've been invited to provide an article for a special issue of HPV World. The issue is called The Critical Role of Modelling in Informing Policy and Planning for Prevention and Control of HPV-related Cancers. And we've been invited to contribute an article where we'll summarise modelling work on the implications of COVID-19 for cervical screening and aiming to submit this by the end of July. We're also preparing an article to submit by the end of June, which looks at the health impacts of screening disruptions stratified by time since last screen and frequency of screening. So teasing out some of the real world heterogeneity in screening behaviour and the implications of this, and hoping that this will have implications beyond the specific example of COVID. And finally, in preparation for contributing to the global modelling of the impact of disruptions to screening, we've undertaken a review of cervical screening in the 83 high-income countries prior to the pandemic, looking at program design and coverage. And that's all from cervix. Thank you.
Thank you very much, Megan. Now, finally, moving to CRC and Dr. Vile Coupe, over to you.
Thank you very much. Yes, next slide, please. So in previous projects, we have assessed the possible impact of hypothetical COVID-19 related disruptions to colorectal cancer screening and alternative strategies to mitigate the impact of these disruptions using limited colonoscopy resources. As data is now emerging, the Working Group 2 has completed an extensive study on the global impact of colorectal cancer screening decreases related to COVID-19. We also generated estimates of the long-term cancer burden caused by these decreases, and we have quantified the impact of catch-up screening. Next slide, please. The analysis was performed by 4 modeling groups, and in consultation with the CCGMC, we have included over 30 countries for which we had identified organized screening programs with participation data. For each of these countries, we observed decreases to screening based on available data, or when this data was not available, we estimate this decrease based on COVID-19 mortality rate. Then next, we generated a model-based estimate of the global impact of the observed and estimated decreases to screening and the benefit of providing catch-up to individuals who missed their screening. Next slide, please. This slide shows the estimates of the global impact on colorectal cancer incidence and mortality over the next 3 decades due to the decrease in screening in 2020. It was predicted that these disruptions lead globally to over 16,000 additional CRC cases. That's the blue line on the left, and nearly 10,000 additional CRC deaths, the blue line on the right. By providing catch-up screening for those that missed screening in 2020, the orange lines, these increases in cancer cases and deaths are reduced by over 80%. Next slide, please. So this work shows that a temporary decrease in screening will significantly impact CRC burden over the next 3 decades. Real-world data are still limited, but have been used to inform these estimates. When real-world data of a country becomes available, the results of this study can easily be used to derive estimates for that country. Catch-up screening should be encouraged if health resources can be allocated. We plan to submit this work later in June to the special edition of eLife on COVID and cancer screening. Thank you.
Thank you, Virle. And a special thank you to all of the teams involved and the 3 working groups. Really impressive amount of work done over the last year or so. We're going to move on to working group 3 now, prevention, and Dr. Peter Sarch is going to talk to us about changes in smoking behavior in the early phases of the pandemic. Peter, over to you.
Thank you. Next slide, please. So we've recently published our systematic review, and we sort of gave an overview of the results of this last time. So I'll just give a little bit of background again. So we aimed to perform a systematic review and meta-analysis to assess smoking behavior changes during the early phases of the COVID-19 pandemic, and we performed literature search up to November 2020. And the outcomes we looked at were changes in tobacco smoking intensity, prevalence, frequency, uptake and cessation, increases and decreases in smoking, and motivations and attempts to quit. Next slide, please. And our meta-analyses indicated overall a slightly lower smoking prevalence during the pandemic. However, the proportion of smokers who smoked more was slightly higher than the proportion of smokers who smoked less. So smoking behavior changes during the early phases of the COVID-19 pandemic were highly heterogeneous. And also the majority of included studies were at high risk of bias. The scope of this review is focused on population level changes and not on specific targeted groups that are known to be at high risk. And updates of this review are planned to assess longer term changes during the pandemic and to consolidate high quality evidence from representative surveys. And if you're interested in reading more, our review is now published in the journal eClinical Medicine. Thank you.
Thank you, Peter. Really important work. All right, next we're going to move forward with an update on the CCGMC global modeling and specifically the OSCAN work. And we have Dr. Joaquim Worthington and Dr. Juolu Sun to take us through this.
Thanks, Rami. Next slide, please. Yeah, so for OSCAN Group, it's a modeling collaboration between teams from the Daffodil Center in Australia and McGill University, Canadian Partnership Against Cancer, and the Canadian Centre for Applied Research in Cancer Control in Canada. Next slide, please. So the group's aim is to look at the full spectrum of cancer control impacts by COVID, including screening, diagnosis, and treatment disruptions. And we are starting off with Australia and Canada with an initial focus on lung cancer, breast cancer, cervical cancer, and colorectal cancer. And today I'll be presenting an example of some exploratory work completed for colorectal cancer. And in the meantime, we have already set up a policy advisory group with representatives from both countries. Next slide, please. So for the screening part, this piece of work follows on from the previous work completed by Working Group 2. So using decreases in screening based on local participation data, we projected impact on long-term outcomes, including number of cancer diagnosed and stage of cancer at diagnosis. Next slide, please. So this next slide, we've extended to delays to diagnosis. So the idea here is that decreases in colonoscopy are assumed to lead to increased longer waiting time before diagnosis of colorectal cancers. And it will in turn lead to cancers being detected at later stages with worse prognosis. Next slide, please. So similarly, we look at the delays to treatment, and similar to diagnosis, treatment delays were assumed to cause worse survival outcomes, and this is based on previous work by Hannah, etc. in 2020. Next slide, please. So our very preliminary exploratory results show that without mitigation over the next decade, the combined effects of screening disruption and diagnostic and treatment delays would lead to an additional 1,000 cases and 6,000 case deaths in Canada, and 380 cases and 700 deaths in Australia. And 90% of these additional deaths were attributable to diagnostic and treatment delays in Canada, 30% for Australia, and the remainder 10% and 30% were due to screening disruptions. So for mitigation strategies, increasing treatment capacity from 2022 to 2027 would avert approximately 3,000 deaths in Canada and 240 deaths in Australia. Next slide, please. So for our next step, we plan to continue to look at more detailed real-world scenarios as we get more up-to-date data. We also plan to do additional modeling of different mitigation strategies. And we also plan to extend our projections beyond 2020 disruptions. And as mentioned, we will expand our modeling into other cancers, including breast, cervical, and lung cancer. So that's our updates from Outcome Group. Thank you.
Thank you so much, Ulu. It's really interesting to see how a modest increase in capacity can make such a significant impact on reducing avoidable deaths. And the difference in the numbers between Australia and Canada are quite interesting, which reflect the severity of the disruptions in Canada relative to Australia. So thank you for that. Well, I think we've actually caught up now time-wise, so we are right on time. And I think we've sort of dedicated the last 5 minutes to looking ahead, looking at some of the new opportunities for the next year or so. And Karen, are you leading that part? And then there's something about rebranding as well.
Yes, yeah, happy to talk to this. Thanks, Rami. So we, in the last few minutes, we were really keen to bring to you all some of the recent thinking of the CCGMC steering group. And you've heard about our hopes for a really significant presence at the World Cancer Conference. So it's really driving some of our thinking about making sure that we present the right public face at that conference, which obviously is an important means of engaging with our target audience of policymakers, essentially. So we have been discussing our name and our branding, if you want to use that term, quite extensively. And a few issues have been raised by the steering group and by you as members and by externals that are interacting with us about our name, CCGMC, and as a moniker. Firstly, it is a very technical name, and it speaks, at least to some extent, to what we do rather than what we're trying to achieve. So it doesn't in fact capture our vision or even all of our current activities. So because we are, of course, as you've heard today, doing much more than just modelling per se. And perhaps one way to capture what we're doing and will continue to do is that we're collating the best evidence and consolidating information on best practice mitigation to provide tools for policymakers. So much more than simple theoretical modelling, if you like. The other aspect that we've been thinking about in a lot of detail is how pertinent COVID is per se to our activities, because of course the predictions and the emerging impact of interventions that might be used in mitigation to COVID are actually part of a broader class of potential interventions, as well as sort of playing into the fact that COVID is actually just one of the challenges in strengthening health services, particularly in LMIC. And COVID is could be seen as the latest in a series of long-standing issues, of course, in strengthening health systems. And our work clearly has potential to speak to some of these broader issues as we go forward. Of course, COVID is now fundamental to the landscape of cancer control. But as we think more and more about mitigation and recovery, perhaps our work speaks more broadly to strengthening outcomes more generally. So we have been thinking, and this is not a decision that's been made, but we have been thinking whether we need to think of a more generalizable public-facing branding for the consortium around cancer control more broadly. So we are planning to rename ourselves before the World Cancer Conference. And there are a few current suggestions for new consortium names there. You'll see that some of them, they all drop the word modelling. Some of them actually focus on evidence or research, and the last actually drops COVID-19 as well. You might have better and other ideas, and we would love to hear from you either now in the chat, or we would really like you to email any thoughts on this to the Secretariat at the email on the slide. So with that, I'll just thank everyone before I hand back to Rami to close, but also to let you know that unfortunately Richard Sullivan was unable to join us, but I believe we'll be able to make his slides and all of the slides today, except those that are showing sensitive pre-publication data, will be available on the website, and I think we'll be able to send around a full slide pack with the permission of the presenters. So thank you again to each and every person here for your contributions to the consortium and the great work that's been done. Thanks. Back to you, Rami.
Thank you, Karen. I have my favorite, but I will not bias the voting results. So looking forward to see what people come back with. So on behalf of the partnership at CCGMC, I'd like to thank all of the speakers and your teams for sharing with us your wonderful research and analysis results. It's going to be very consequential to help really decision makers make the right policy and planning decisions around helping the system respond effectively to the needs of cancer patients in the pandemic, and hopefully we can say post-pandemic at some point in the future. So thanks everyone, and enjoy the rest of your day.
Thanks. Bye, everyone.
Bye.